Very good evening to all. I guess you can hear me. Can someone respond in the chat box that you can hear me? Can I start the session? Someone please respond in the chat box. Yes, thank you, Revati. Thank you so much. Okay, so I think we have already covered cholinergic nervous system, cholinergic system, isn't it? So cholinergic அப்படின்னா என்ன? Very easy. Cholinergic அப்படின்னா acetylcholine அப்படிங்கிற அந்த ஒரு particular is going to act on the acetylcholine receptors and produce various symptoms. That is what entire parasympathetic system is going to cover. Now what we are going to do is we are going to move towards the opposite of a parasympathetic system. If you all remember, when I started with the parasympathetic nervous system drugs, I told you parasympathetic nervous system is the one that is going to act at a state of relaxation. That means when you are going to sit relaxed, you don't want to get worried about things. At that point of time, what you will do, you will eat food. While you are eating food, what all the things has to be done? Okay, you don't need to be vigilant. You don't need to prepare yourself for a fight and flight movement. Okay, that is the exact term I used when we started with the cholinergic drug. What is adrenergic drug? Exactly opposite to that is your adrenergic. The prime function of a adrenergic system or your sympathetic nervous system is to help the human beings to prepare ourselves for stress, to prepare ourselves for a stressful conditions and to fight that stressful condition. That means when we are exposed to some stress, what will happen? Your heart rate will be increasing. Remember, your heart rate will be increasing. Then what happens? Once your heart rate is going to increase, automatically, what are the other things that are going to happen in your body? The blood supply that is needed to the heart must be raised. Very clear, right? So whenever the blood supply to the heart has to be raised, then what happens? The peripheral supply of blood, like your skin, like your gut, and the places where the blood supply is not at all necessary at a situation of an emergency, then அந்த இடத்துல இருக்கக்கூடிய blood supply will be shifting to the vital organs. What are the vital organs in your body? Your brain, your heart, your kidney. All these things are very important. And remember, when you wanted to fight some situation, your muscles are very much required. Therefore, what happens? The blood supply to the muscles has to be ensured. So to ensure the blood supply to the muscles, what happens? Your blood supply is diverted. Okay, wow. So this is a simple logic behind the adrenergic transmission or adrenergic nervous system. ஓகே, இங்க நமக்கு என்ன வேணும் அப்படின்னு பார்த்தோம்னா, ஒன்னு ஹார்ட்டுக்கு பிளட் சப்ளை ரைஸ் பண்ணணும். அட் த சேம் டைம் you have to run, you have to fight. That time what happens? You need a more oxygen supply. அப்ப உங்களோட bronchus has to be dilated. So bronchus dilated ஆனாதான் ஆக்சிஜன் வந்து நிறைய இன்டேக் இருக்கும். So what is the action of your sympathetic system? It has to bronchodilate. Clear? Number 2. Number 3 என்னது? It is also necessary to have a good vision. Then what happens? உங்களோட vision should be broader. Your vision should be broader. Therefore, there is going to be dilatation of your pupil. There is a dilatation of your pupil. Similarly, you need more energy, isn't it? To fight a emergency situation, you need a energy. To ensure that proper energy is given, then you need a proper supply of glucose. So proper supply of glucose எப்படி maintain பண்ண முடியும்? By increasing the glycogenolysis. Is it clear? I think I am making a good story. So இது எல்லாமே ஒரு story தான். So just imagine. So நீங்க ஒரு dog is chasing you. This is a frequent terminology given by any faculty. ஒரு dog is chasing you. What all you need to do? You have to run, you have to think. So at that point of time, what all the system is going to function, that comes under your sympathetic nervous system. Is it clear up to this? Yes. So your sympathetic division consists of thoracolumbar outflow that is going to extend from the first thoracic to second or third lumbar vertebra, paravertebral areas. So since this slide it's a starting of pharmacology, but pharmacology is not necessary. What you need is to understand the basic concept and put a foundation for it. So anatomy, physiology, all these things are going to be interrelated. Okay, so now coming towards sympathetic system na enna theriyum. Appa next enna pannom, neurotransmitters. So ipo or parasympathetic nervous system ku na first edutone enna sonnen, you are going to have a acetylcholine. Similarly for a sympathetic nervous system, what you need is noradrenaline and dopamine adrenaline. Okay, noradrenaline, dopamine, adrenaline, otherwise called as norepinephrine. So the ultimate system of your sympathetic nervous system, stimulation is going to be mediated by norepinephrine. Okay, norepinephrine. So this norepinephrine is the one that is going to activate adrenoreceptors. That is the one that is going to activate adrenoreceptors. Clear? So the drug that mimic the action of your epinephrine or your norepinephrine is called as sympathomimetic drug. Ivladhan concept. Okay, whichever is going to activate your sympathetic nervous system, you call it as a sympathomimetic drug. Okay, normally adrenaline or your epinephrine, that's the major hormone that is secreted by your body. Enga secrete agudhu? Adrenal medulla. So which is going to contain 85% adrenaline. Okay, so 85% adrenaline. Appa noradrenaline enadhu? 15% da noradrenaline. So how this noradrenaline? So first உங்களுக்கு noradrenaline தான் secrete ஆகும், அதுல இருந்து adrenaline convert ஆகும். அந்த system தான் we are going to see now. Okay, so displace storage catecholamines from the adrenergic nerve ending. So that is the main action of your sympathetic nervous system. What does your sympathetic nervous system do? Sympathetic nervous system is going to displace your catecholamine from the adrenergic nerve ending. So this is your adrenergic nerve ending. So in the adrenergic nerve ending, first you are going to have is phenylalanine. So in phenylalanine da first irukum. Phenylalanine. In the phenylalanine, they are going to convert it into tyrosine. They are going to convert them into tyrosine. So the three endogenous catecholamine like your noradrenaline, adrenaline, dopamine, ivanga moonu perume, they are synthesis from the amino acid termed as phenylalanine. Clear? In the phenylalanine and the tyrosine varudhu. In the tyrosine is going to get converted into dopa. Tyrosine is going to get converted into dopa in the presence of tyrosine hydroxylase. Tyrosine hydroxylase. Idu varaikum edha doubt iruka? இப்ப இந்த டைரோசின்ங்கற காம்பவுண்ட் வாட்டர் ரிமூவ் ஆகுது, ஹைட்ரோலைசேஷன் நடக்குது to give rise to dopa. So இந்த dopa என்ன பண்ணுது? Decarboxylation நடக்குது. So the dopaல decarboxylation நடக்குது to form dopamine. So dopaல decarboxylation நடக்குது to form dopamine. Now what happens? Your dopamine is going to get converted into noradrenaline. In the step very, very important. So your dopamine is going to get converted into noradrenaline in the presence of DA beta hydroxylase. So in the presence of beta hydroxylase. Adikapro noradrenaline is going to get converted into adrenaline in the presence of N-methyl transferase. In the whole step தான் நீங்க biochemistry la படிப்பீங்க. Okay va? So next coming towards இது வரைக்கும் ஏதாவது டவுட் இருக்கா? If you are not having any doubt, what happens is I'll tell you. இப்ப இந்த step you have to remember. So இது வரைக்கும் noradrenaline form ஆன வரைக்கும் I told you. Once the noradrenaline is formed, okay, your sympathetic postganglionic nerve fibers that synthesis, store and release your noradrenaline is called as your adrenergic system. இந்த part தான் நம்ம adrenergic part அப்படின்னு நம்ம சொல்றோம். இப்ப ஒரு nerve impulse வருது. Nerve impulse வந்தா என்ன ஆகும்னா your noradrenaline is going to be released. Your noradrenaline is going to be released. into the synaptic cleft by the process called as exocytosis. So once exocytosis nadandona, in the noradrenaline enna pannona, they are going to bind with the adrenergic receptors. Appa next question ungalku enna varano, what are the different types of adrenergic receptors? Adha next slide la nama paaka porom. So ungalku alpha beta, for now remember alpha beta ante rendu receptors irukku. And the receptors la poi idu bind aga pogudhu. Small portion of noradrenaline, what happens, they are going to get metabolized by the enzyme called as COMT. Okay va? So by the enzyme called as COMT. What is COMT? Adha na inga kuduthirken. Catechol O-methyl transferase. Catechol O-methyl transferase. That's COMT. So large portion is however taken back into the nerve terminals by a energy dependent transporter that is called as uptake 1. Idhula edha doubt iruka? Enna agudhu? Uptake 1 அப்படிங்கற அந்த transporter is going to retake all the adrenaline or all the norepinephrine that has come out from the adrenergic terminal. So இது என்ன பண்ணும்? It is going to end the action of noradrenaline. ஒரு செக் வைக்குது. So நிறைய noradrenaline secrete ஆயிட்டே இருந்தா என்ன ஆகும்? It is going to cause adverse effects. So அப்ப அதை prevent பண்றதுக்காக நமக்குள்ளேயே இருக்கிற ஒரு feedback mechanism தான் இது எல்லாமே. ஓகேவா? So the nerve terminal takes up your noradrenaline with the help of amine pump norepinephrine transporter. அதுதான் NET. So what is NET? Norepinephrine transporter. Norepinephrine transporter. Is it clear? Is it clear till now? Yes. Of this, a fraction is going to be metabolized by MAO. What is MAO? Again, I'll tell you, monoamine oxidase. This is monoamine oxidase. The monoamine oxidase enna pannona? Okay, mitochondria la irukum. So the remaining noradrenaline is transferred to store into vesicles. So apra thirupi enna pannum? Noradrenaline in the presence of monoamine oxidase, it is going to take it into the vesicles. Vesicles le thirupi pogum. In the vesicles la thirupi anupanona, anga oru transporter தேவைப்படும். அதுதான் VMAT2. What is VMAT2? Vesicular monoamine transferase. So வெளில first பார்த்த என்ன பார்த்தோம்? So you have catechol O-methyl transferase. இங்க என்ன இருக்கு? Vesicular M for என்ன? Monoamine transporter. So vesicle monoamine transporter 2. Is it clear? இது வரைக்கும் any doubt is there? So in the concept you have to know. எதுக்கு நான் இதெல்லாம் தெரிஞ்சுக்கணும்? நெக்ஸ்ட் क्वेश्चन உங்க கண்டிப்பா கேட்பீங்கல்ல. நான் ஏன் இந்த இத வந்து நான் தெரிஞ்சுக்கணும்? I am going to study the drugs, isn't it? Why I have to read this? Why I have to understand this particular picture? Very, very important. Because the target of the drugs are going to be in this picture alone. Okay, let it be agonist or antagonist of your adrenergic. The entire target is going to be occurring in this particular system. So adinala in the system I have taken 5 minutes of my time to teach you the concept behind it. Idhila edavadhu doubt irundha kindly ask in the chat box. If not, I will proceed to the next one. If you don't have any doubt also, kindly put in the chat box that everything is clear so that I can satisfiedly go to the next topic. Clear. Thank you, Jayashri. If it is clear, I'm very happy. Now, moving on towards the adrenergic agonist. Before I move towards the adrenergic agonist, what I will do is I'll tell you one important concept. Okay, I'll tell you one important concept. So remember the adrenergic receptors. So in the adrenergic agonist act pannuna, you need to have a adrenergic receptors. You need to have a adrenergic receptors. The adrenergic receptors are of two types. One alpha, இன்னொன்னு beta. Okay, now talking about this alpha is again divided into alpha 1 and alpha 2. Again it is divided into alpha 1 and alpha 2. Again this alpha 1 is divided into 1A, 1B, 1C. Not C, sorry, 1D. 1A, 1B, 1D. What is all these things? I'll tell you later. And alpha 2 again, it is divided into A, B, and C. So A, B, and C. அது மாதிரி மூணா நம்ம பிரிக்கிறோம். Similarly, beta is divided into beta 1, beta 2, beta 3. இவ்வளவுதான். இதுல ஏதாவது டவுட் இருக்கா? If you are not having any doubt, I'll tell you. இந்த alpha receptor, beta receptor அப்படின்னு ரெண்டா பிரிக்கிறோம்ல. இதுல the alpha receptors ஓட, so the stimulation of alpha receptors are mainly going to produce excitatory effect. Always remember the stimulation of alpha receptors. Okay, stimulation of your alpha receptors are going to mainly be excitatory, whereas the function of your beta stimulation is going to act as inhibitory. Beta is always going to be inhibitory. So anything in our body will always have a exclusion. And the my or exclusion na alpha ku GIT. GIT la alpha da irukku. Ana alpha receptors will be causing inhibition. Whereas beta ella edathila inhibit pannu except your anyone? Cardiovascular system, where it is going to cause stimulation of your heart. Is it clear? Okay, so the stimulation of your presynaptic alpha 2 receptor. So idhili or exclusion irukku. The presynaptic alpha 2 receptor will be inhibiting the further release of your noradrenaline. Thus alpha 2 receptors will be acting as a feedback mechanism. Alpha 2 receptors will be acting as a feedback mechanism. So இங்க என்னென்ன பாயிண்ட் நம்ம படிச்சிருக்கோம்? ஆல்பா பீட்டா ரெண்டு இருக்கு. ஆல்பா வந்து excitatory except in GIT which is going to inhibit. Beta always inhibitory except in CVS which is going to be stimulatory. Similarly, adrenergic receptors alpha beta அப்படின்னு ரெண்டு இருக்கு. ஆல்பால alpha 1 alpha 2 இருக்கு. Alpha 1 is further divided to A, B and D. Alpha 2 வந்து A, B and C. What you have to remember here, alpha 2 acts as a feedback mechanism. Okay, so alpha 2 is also present in the postsynaptically in the pancreatic islet, platelet and your brain. So this is what you need to know. Okay, now endogenous catecholamines abdinu one irukku. What is this? I'll tell you. So endogenous catecholamines now which are produced by our body, that is your adrenaline, noradrenaline, dopamine. Adrenaline is going to act as a transmitter at the postganglionic sympathetic sites. Adrenaline secreted by your adrenal medulla. Dopamine, basal ganglia, limbic system, CTZ and your anterior pituitary. All your reward systems irukilla. All your reward system is going to be basically a dopamine. So ipo nama padikirona chocolate saapilla appdi nama padikirona vechukonga. So and or reward system irukilla, positive reward system, adu vandu dopamine da. So indu already na ungalku solten phenylephrine eppadi phenylalanine eppadi tyrosine to dopa to dopamine to noradrenaline, noradrenaline to adrenaline. This concept full I told you. Okay, so now the effect of catecholamines are remediated by the cell surface receptors. Adrenoreceptors are typically G protein coupled receptors. Very important MCQ. So for the one who are going to be in the CBME pattern, this can be asked as a MCQ. The receptor protein has an extracellular N terminus and intracellular C terminus. Okay, ஒரு receptor protein ko rendu terminus irukku. N terminus, C terminus. This is going to be again a toppers question. Okay, so normal argonga, no need to remember. Toppers, please remember these are the two types of the receptor protein. Now that transverses the membrane 7 times forming a 3 extracellular 3 intracellular loop. So idu enna pannuna indha mai or loop structures form pannum. I'll show you. So there will be a loop structure formation. Clear? So there will be a loop structure formation. So that is why you are going to have. Now G protein is a heterotrimer. Okay, what is a CTZ? Yeah, someone asked Dinesh, right? Yeah, what is a CTZ? CTZ abdingadhu, it's a vomiting center nama solluvom usually. CTZ is nothing but it's a vomiting center. Okay, so that is going to be present in your brain. So this is full form vandu pathina chemoreceptor trigger zone appdi nama solluvom. What is it? It is a chemoreceptor trigger zone. Always remember, it is a chemoreceptor trigger zone which is located in the dorsal surface of your medulla. So this is going to be located where? It is going to be located in the dorsal surface of your medulla. Okay, va medulla oblongata. Okay, exacta solnona fourth ventricle of the brain la locate aayirukkum. Exacta solna fourth ventricle oda brain la vandu locate aayirukkum. Dinesh, is it clear now? Good. So next I go for the G protein. So in the G protein, it's a heterotrimer which is going to consist of alpha, beta, gamma subunit. So G protein coupled receptors nale indha maari dhaan irukum. So they are classified based on the alpha subunit. So idu edella vandu activate pannu or which all going to determine appdi nama paathona, you are going to have adenyl cyclase, cyclic GMP, phosphodiesterase, phospholipase C, ion channels. Idella they are going to act on it. So idu vandu typical biochemistry. This is not required for you. Just remember they are going to be G protein coupled receptor in the slide la what you are going to take home is, so it's a G protein coupled receptor and it is going to form a 7-time loops forming a 3 extracellular 3 intracellular loop. Okay, so adrenoreceptors were initially characterized pharmacologically as alpha receptors, beta receptors. Alpha receptors la vandu epinephrine more action irukum, beta receptors la isoprene more receptors more action irukum. Now alpha receptors I already told you alpha 1 alpha 2 abdin renda pirikirom. Alpha 1 is a G protein coupled receptors. Alpha 1 la again it is divided into 3, alpha 1A, 1B and 1D. Beta la namak eppadi divide pandrom, beta is divided into B, alpha 2 is divided into alpha 2A, 2B, 2C. Alpha 2 is a feedback mechanism controller. Avladhaan namak theriyano beta. Okay, in the table the next important thing. Okay, once you understand what is alpha, what is beta receptor, now next thing what you have to remember is where is your alpha receptor, where is your beta receptor. So that is what you are going to see now. Now consider only your alpha. So if or alpha receptor activate pannona, okay, or nerve endings lende alpha receptor activate agudhu. Alpha receptor activate aanona next enna aga pogudhu. So next step enna aguna phospholipase C abdingra enzyme activate agum. The phospholipase C abdingra enzyme enna aguna, they are going to go through the generation of second messenger. What is your second messenger? So you're going to have IP3-DAG system. This is again an MCQ for you. So IP3-DAG, again I told this especially in the cholinergic section also. IP3-DAG system la work pannakodiya, so idella vandu ungalku very very important. So calcium main vandu IP3-DAG oda main process enna calcium. Okay, so appa calcium increase ana enna agum, there is going to be contraction. There is going to be contraction of muscle. But inga எந்த muscle la idu act பண்ண போகுது அப்படிங்கிறது தான் நமக்கு ரொம்ப important. Okay, so this is going to increase your intracellular calcium, and once your intracellular calcium is increasing, it is going to cause contraction of your muscle. Okay, so this is important. Second thing நம்ம என்ன பார்க்க போறோம், beta. So beta receptor அப்படிங்கிறது எது வழியா ஆக்ட் பண்ணுதுன்னா, it is going to act via adenyl cyclase. Adenyl cyclase என்ன பண்ணும், it increases the cyclic AMP level. So this secondary messenger is going to cause various intracellular proteins to bring the changes inside the idhu. Okay, is it clear till now? Okay, now coming to the alpha 1 receptor. Alpha 1 receptors are always present and most probably present in the vascular smooth muscles. It is going to present in the vascular smooth muscle, alpha 1. Okay, in the vascular smooth muscle enna pannu, it is going to cause contraction. Once there is a contraction, there is going to be a IP3-DAG. IP3-DAG enna pannu, calcium increase pannu. So this is going to be your action in your vascular smooth muscles. Next, gut. Or gut is nothing but your stomach. So gut or GIT idhila eppadi act pannadhu, you already know they are going to cause relaxation. Then what happens in your genitourinary smooth muscles? Let it be a prostate or anything. So genitourinary prostate idhila vandu eppadi act pannadhu, contraction. Liver la enna action pannadhu, liver la vandu this is going to cause glycogenolysis. Clear? This is doubt. Next, we are going to go for the alpha 1 la heart. Okay, heart la vande there is very very mild. Okay, you are going to have very mild action in your heart. So heart la periya function kadayadu alpha 1 ku. So alpha 1 is going to cause increase in the force of contraction. Normally alpha 1 is going to cause increase in the force of contraction. Clear? Next, coming towards the alpha 2. Alpha 2 vande post-synaptic nerve terminals. Post-synaptic nerve terminals alpha 2, they are going to cause a feedback mechanism. They are going to cause a feedback mechanism. So, adinadam post-synaptic CNS terminal, neuroterminal, I have mentioned as multiple function. Why? Because initially they will cause a norepinephrine release, but later they are going to be acting as a feedback mechanism. They are going to prevent the release of the noradrenaline or norepinephrine. Platelet, it is going to cause aggregation. Again, pancreatic B cells, rumba important function. They are going to decrease the insulin release. They are going to decrease the insulin release. Remember, pancreatic beta cell or pancreatic beta cell. Beta vardu. Beta nale enna sonna? Inhibition sonna. Or there is going to be inhibition. Appa beta nale inhibition na. Then what happens? There is going to be a decrease in the insulin release. Okay, va? Is it clear? Next, coming towards your beta 1. Beta 1 very, very important because they are going to deal with your heart and your juxtaglomerular cells. What it does, it is going to increase the force and rate of contraction. It is going to increase the renin release. Okay, so beta 1 is going to cause increase in the force and rate of contraction. It is going to cause increase in the renin release. Similarly, next you are going to go for the beta 2. Beta 2, it is going to be a smooth muscles wherever it is present. Let it be your vascular, let it be your bronchial, let it be your gut, let it be a genitourinary tract. In the they are going to ultimately cause relaxation. So that is the main reason we are going to call, isn't it? So they are going to cause relaxation. So relaxation of the smooth muscles. Okay, and then beta 3. What is the role of beta 3? Mainly beta 3 is present in the adipose tissue. Mainly your beta 3 is going to be present in the adipose tissue. Is there any doubt till now? So what happens in the adipose tissue? It is going to activate your lipolysis. Clear? Any doubt up to this? So this is going to summarize the entire action of your adrenergic system. Okay, this one tabular column is going to entirely tabularize or entirely it is going to tell about the functions of your adrenergic nervous system. That is why I'm repeating once again. If you have any doubt, you can ask me at this point of time before moving towards the next slide. Is it clear? Someone respond, please. Is it clear? All right. Thank you. So what we are going to see here is, now you know the different receptors. You know the different receptors, where all they are present, everything you know. Now, this receptor must have a regulation. How does this is regulated? This is regulated by the catecholamines. It is regulated by the age, by the hemostasis. So, okay, sorry, homeostasis. What is homeostasis? A feedback mechanism and a homologous heterologous down regulation. So, this is the chemistry of your sympathomimetic drug. Now, we are moving slowly into the sympathomimetic drug. I will tell you. Okay, so if you all have your very important textbook that I asked you all to have in your hand, what is it? Anyone? What is it? I asked you to have in your hand, right? That one book. Exactly. So this is the one I asked you all to have in your hand. So that is the Tripathi classification of drug. So this one particular tabular column you need to remember. Okay. So how you are going to remember? Remember. So the entire adrenergic drugs, or you call it as a sympathomimetics, that are going to mimic your sympathetic system action. So that you have to remember. So all these things, you can divide these sympathomimetics based on two important things. One, you can remember with the help of how this is present. So what is the chemistry behind it? So with that you can remember. Or second thing is, you can remember by the action of it. So the one which I have put in the slide is going to be the action. One I am going to put in your slide is going to be depending upon the action. The one given in your Tara Schemberg is classification of sympathomimetics based on the chemical structure. So based on the chemical structure, you can classify it as two important categories. One is catecholamine, second is non-catecholamine. So what is this catecholamine? Anyone? What is this catecholamine? So I'll tell you, catecholamine, it is going to have a catechol nucleus. Why you call it as catecholamine? You need to know, right? So catecholamine, catechol nucleus and solvo. Okay, so this is going to be your catechol nucleus. So you're going to have 1, 2, 3, 4, 5, 6. Okay, this is going to be a catechol nucleus. Here you're going to have a carbon. Okay, here you're going to have a carbon, and at the end you will be having a nitrogen. So this is going to be called as catecholamine, and you will be having two hydroxy structures at the 2 and 3 and 4th place. So this is called as a catechol structure. In the structure la irukra drugs adha neenga catecholamines nu solveenga. So what are the drugs that are present in this structure? One is your adrenaline, noradrenaline, dopamine, isoprenaline, and your dobutamine. Isoprenaline and your dobutamine. And what is the non-catecholamine drugs? So sympathomimetics that is not going to have catecholamine is going to called as non-catecholamine drug. So example is going to be your, example is going to be your phenylephrine, salbutamol, tyramine, ephedrine, amphetamine. Salbutamol, tyramine, ephedrine, salbutamine. Okay, so this is going to be your adrenergic drugs. So, but in exam, if you ask me, you can remember based upon the clinical classification or your clinical usage, and that is what given in your KD Tripathi's drug classification. So you are going to divide it into pressor agent. What is pressor agent? Okay, which is going to cause increase in the cardiac output. Eppadi increase pannum? Vasoconstriction மூலமா. So that is your pressor agent. Second thing is a cardiac stimulant. Third thing is going to be bronchodilator. Fourth one is nasal decongestants. Okay, nasal decongestants. Fifth one is going to be CNS stimulants. Fifth one is going to be, CNS stimulants. Then sixth one is going to be anorextics. Seventh is going to be uterine relaxants. Okay, so uterine relaxants. So these are the 5. In the classification, understand these are going to be your functions of your sympathetic nervous system. Very clear, right? This is the function. You're going to remember. Okay, now what I'm going to do is in the function so this First, I'll start the pharmacological action with the heart. So heart you're going to have the beta-1 receptor. Okay, it's a beta-1 receptor mediator. Your adrenaline is going to increase the heart rate. How? By increasing the slope of slow diastolic depolarization of cell in your SA node. Always remember, the entire action of your autonomic nervous system is going to be depending upon the SA node. It is going to be depending upon the SA node. So it is going to increase the slope of slow diastolic depolarization cells in your SA node. So this is how what it does. It is going to increase the force of contraction, cardiac output, and conduction velocity. So the work done by the heart and the resultant oxygen consumption is also increased. Your problem is, so there is an increased work done by the heart. There will be increased. Okay, what happens? There will be increased. What happens? There will be increased. Anyone? There will be increased oxygen consumption. So there will be increased oxygen consumption, and because of that, you are going to have a increased oxygen demand for your cardiac cells. Okay, so that is your that is going to be one point. Second thing, arrhythmias are going to occur. Okay, because there is a marked rise in the BP. So this is going to in turn depresses your SA node and it unmasks your latent pacemakers. So I'll tell you the concept. So heartbeat raised. So there is going to be a tachycardia. Okay, ultimately what happens is vasoconstriction ஏற்படுது. அப்ப BP raise ஆகுது. ஒரு லெவலுக்கு மேல BP raise ஆகறப்ப your body's homeostasis, or your body's feedback mechanism, what it does is it is going to decrease the cardiac contractility. So how it does, it is going to depressing your SA node. Appa SA node depress agudhu, but ultimately you need your heart to pump the blood. Therefore, what happens? It is going to unmask your latent pacemaker. Then force of cardiac contraction is also increased. Cardiac output and oxygen consumption of heart are going to be markedly enhanced. So cardiac consumption is also going to markedly enhance. Is it clear? Okay. Now, what happens to the individual things? I'll tell you. Okay, va. So what happens to the individual things? Okay, va. One thing is blood vessels. So first என்ன பண்றோம்? Blood vessels. So both vasoconstriction, alpha and beta vasodilatation, beta 2. So remember, alpha என்ன பண்ணும்? Vasoconstriction பண்ணுது. Beta 2, what it is going to do? It is going to cause vasodilatation. So இப்போ எங்க? So இப்போ உங்களுக்கு ஒரு question வரும். அப்ப ரெண்டுமே ஒரே நேரத்துல நடக்குதா? It is not like this. சில ஏரியால ஆல்பா பிரசன்ட் ஆயிருக்கும், அங்க வாசோ கன்ஸ்ட்ரிக்ஷன் நடக்கும். சில ஏரியால வாசோ டைலட்டேஷன் நடக்கும், அங்க பீட்டா ரிசெப்டர் பிரசன்ட் ஆயிருக்கும். இப்ப வெரி கிளியரா? சோ நான் என்ன சொன்னேன்? ஆல்பா இஸ் கோயிங் டு ஸ்டிமுலேட், பீட்டா இஸ் கோயிங் டு inhibit. So இங்க constriction, அங்க dilatation. But எந்த பிளேசஸ்ல? So எங்க constriction நடக்கணும்? Blood vessels எங்க constriction நடக்கணும்? When just logically think பண்ணுங்க, peripheral areasல constriction நடக்கணும். Example is cutaneous, mucous membrane, renal beds. அதே மாதிரி எங்க dilatation நடக்கணும்? Where there is should be a more blood supply. Example your skeletal muscle, example is your liver and your coronary blood system. So அங்கெல்லாம் உங்களுக்கு ஆக்சிஜன் டிமாண்ட் நிறைய இருக்கு. So அங்க வந்து வாசோ டைலட்டேஷன் நடக்கணும். வாசோ டைலட்டேஷன் நடக்கணும்னா அங்க என்ன ரிசெப்டர் பிரசன்ட் ஆயிருக்கணும்? பீட்டா 2. வாசா கன்ஸ்ட்ரிக்ஷன் நடக்கணும்னா அங்க என்ன ரிசெப்டர் பிரசன்ட் ஆயிருக்கணும்? ஆல்பா. Clear? So in the concept that many people will be missing, and that is the reason why you get confused at the exam. So am I clear to you all? If you have any doubt, just tell me at this point of time so that I can proceed to the next one. Is it clear? Shall I move to the next one? Someone? Thank you. Okay, next we are going to move towards the blood pressure. So for blood vessel, blood pressure, இது ரெண்டுமே வந்து ஒரு complex system. Okay வா? So the effects on BP are complex. Why? Because as I already told you, both your alpha and beta are going to be stimulated by the adrenaline. So blood vessel of your skin, mucous membrane are going to be constricted, whereas your skeletal muscle is going to be dilated. So அப்ப என்ன ஆகும் அப்படின்னு பாத்தீங்கன்னா, your noradrenaline beta 2ல ஆக்ஷனே கிடையாது. இப்ப beta 2ல ஆக்ஷனே கிடையாதுன்னா skeletal muscle, liver, coronaries-லாம் ஒரு சப்ளை இல்லை. அப்ப ஐசோப்ரெனலின் என்ன பண்ணும்? பீட்டா 1 cardiac stimulation-ம் பீட்டா 2ல vasodilatation-ம் பண்ணும். So this is the isoprenaline. Adrenaline at higher concentration, there will be alpha response. At a lower concentration, it is going to be beta 2 response. So okay va? So மூணு drug நம்ம பார்க்கிறோம். Adrenaline, noradrenaline, isoprenaline. இதுல noradrenalineக்கு beta 2ல ஆக்ஷனே இல்லை. Adrenaline என்ன பண்ணும்? At a higher concentration, alpha receptors. At a lower concentration, beta 2 receptors. Isoprenaline is going to be a beta stimulant. So beta 1 cardiac stimulation, beta 2 is going to be a vasodilatation. Okay va? So when you're going to give a moderate dose of adrenaline, IV-ஆ கொடுத்தீங்கன்னா, it will produce a rapid increase in the BP, which will be followed by a fall. So there will be a rapid increase in the BP followed by a fall. What is this called as? This is called as a biphasic response. So there's a rapid increase followed by there is a decrease. So that is called as the biphasic response. Why? Because the systolic rise is going to be alpha 1 mediated vasoconstriction. Beta 1 receptor அப்புறம் என்ன பண்ணும்? So first என்ன ஆகுது? Systolic rise is going to be due to the alpha 1. Alpha 1 is going to cause vasoconstriction, and there is going to be beta 1 stimulation. What does your beta 1 do? Your beta 1 is going to increase your heart rate, force of contraction, and cardiac output. So cardiac output ultimately increase ஆகுது. Because of it, what happens? There is going to be a rise in the BP. then what happens? கொஞ்ச நேரத்துல ஆல்பாவோட ரிசெப்டர் ஓகே அட்ரினலின் ஹையர் கான்சென்ட்ரேஷன்ல இருக்கப்பதான் ஆல்பா ரெஸ்பான்ஸ், lower concentration போகும்போது என்ன ஆகும்? Only there is going to be a beta receptor action, that is action on your beta receptor are going to be more persistent, and as the action on alpha receptor is going to be slowly weaning off, the action on beta 2 receptor is going to be unmasked. That is going to result in the fall in the blood pressure. So okay, fall in the blood pressure. So beta 2 receptor is the reason for fall in your BP. Okay va, due to the diastolic, okay, diastolic time la there will be a fall in the BP. idha வந்து ஒருத்தருக்கு வந்து he told it. Who is that? DALE, Dale. So ரொம்ப important. So he is the person who told, Sir Henry Dale. He demonstrated that when you're going to block the alpha receptor with the ergot alkaloids, what happens? Your adrenaline is going to produce only fall in the BP. So this is called as Dale's vasomotor reversal or Dale's phenomena. Okay, so you should never forget this Dale's phenomena. Why I am telling this as very important? Because this can be asked as a exam question. Because this can be asked as a exam question. Okay, va? Is it clear? So what is the Dale's phenomena? When you are going to block the alpha receptor, there will be a fall in the BP. Okay, va? Noradrenaline is mainly an alpha agonist. Adhaan na inga sonna. Noradrenaline is going to mainly an alpha agonist. Okay, va? So therefore this brings about the rise in the BP. Okay, that is why this is associated with bradycardia due to baroreceptor stimulator. இது வரைக்கும் ஏதாவது டவுட் இருக்கா? If you are understanding this blood pressure monitoring, blood pressure maintenance, next we are going to go for the respiration. So what happens in the respiratory system? You are going to have this bronchi. So smooth muscles அப்படினாலே உங்களுக்கு என்ன ஆகும்? Relaxation நடக்கும். So adrenaline is a powerful bronchodilator. How it is going to act? It is going to act by the beta 2 receptor. It is going to act by the beta 2 receptor. So noradrenaline is mainly a, okay, so you're going to have this adrenaline. Adrenaline is going to be activated by the beta 2 receptor, and they are going to be a weak respiratory stimulant. So pulmonary vasoconstriction. So idha thavara enna aguna, your alpha action enna pulmonary vasoconstriction. Pulmonary vasoconstriction will also reveal, okay, it is going to relieve your congestion. It is going to relieve your congestion. Therefore, these are very important group of drugs that we use in the respiratory congestion when there is going to be any OAD, obstructive airway disease. Next, you are going to go for the uterus. Uterus la non-pregnant uterus on the contract ago, last month of pregnancy on the ultava, this will cause relaxation. Gut la enna agum? It is going to cause relaxation. Your peristalsis ultava inge eppadi irukum? It will be reduced, and your sphincters are going to be constrictor. Your sphincters are going to be constrictor. Then comes to your splenic capsule. So its splenic capsule enna aguna, this is going to contract. Na G18 adu intestines tubes adha mattum dhaan na solren. Spleen la enna aguna, contract agum. Whenever there is going to be a contraction, this will result in release of RBC into your circulation. This will cause release in your RBC circulation. Okay, va? Now coming to the pilomotor muscles. So pilomotor air follicles ella enna agum? They are going to contract. Then bladder enna agum? Detrusor is going to be relaxed. So inga detrusor relaxed ஆகும், trigone contracted ஆகும். So trigone contract ஆனா என்ன ஆகும்? Urine வெளில வராது. So this is going to be your, it will be like this. Okay va? So triangular இருக்கும். ஓகேவா? So இதான் உங்களோட ட்ரைகான். இந்த ட்ரைகான் என்ன ஆகும்? கன்ஸ்ட்ரிக்டடா இருக்கும். உங்களோட detrusor muscle என்ன ஆகும்? They are going to be relaxed. So because of this relaxation, what happens? What is going to be the effect? They are going to cause increase in the holding capacity of your bladder. ஒரு எமர்ஜென்சி நாய் துரத்துது, அந்த டைம்ல நீங்க யூரின் போகும்னு நிக்க முடியுமா? முடியாது. Simple logic. That is why your detrusor muscle has to be relaxed. Your trigone will be contracted. Clear? Next, I la enna agum? I already told you, adrenaline causes mydriasis. How? By an active mydriasis, by contraction of your radial muscle. How? By contraction of your radial muscle. So there will be a radial muscle contraction. Clear? So once there is a radial muscle contraction, there is going to be an active mydriasis. Why I am meaning the term active mydriasis? Because you can see passive mydriasis in where? In someone, you are going to see passive mydriasis. Anticholinergics. Anticholinergics causes passive mydriasis. Okay, this will also help in reducing your intraocular pressure. This will also help in reducing intraocular pressure. Next, I am going to go for the metabolic effect. Adrenaline increases the blood sugar level. How? By enhancing your hepatic glycogenolysis. It is also going to inhibit your insulin release. So by enhancing the breakdown of your triglyceride in your adipose tissue, more free fatty acid will be available in the plasma. Okay, so more free fatty acid will be available in the plasma. Now coming to the skeletal muscles, catecholamines are going to facilitate neuromuscular transmission by action on both alpha and beta receptor, and they are going to enhance the amount of acetylcholine that will be released. Okay, so this is clear. I think till this there won't be any doubt. Okay, next I am going to move towards the adrenergic drugs. Okay, till now in the mechanism, if you have any doubt, you can ask. Otherwise, we can move towards the individual drugs. I hope there won't be any doubt, and I'm moving towards the drugs acting as a sympathomimetics. Okay, okay. So what happens is you have different preparations. Okay, adrenaline will be in preparation of 1:1000 or 1:10,000 or 1:1 lakh. இந்த மாதிரி மூணு important இதுவா இருக்கு. Usually adrenaline வந்து பாத்தீங்கன்னா it will be coming in a 2 mg per ml or even 1 mg per ml injections are varum. Okay, adrenaline is also coming as a aerosol inhaling 2% ophthalmic solution. In the mind different combinations like your adrenaline is coming. Okay, noradrenaline வந்து பாத்தீங்கன்னா again you will be having in IV infusion அதான் போடுவோம். So 2 to 4 microgram per minute IV infusion will be given. Then you are going to have a isoprenaline. What is isoprenaline? They are going to be 20 mg sublingual drug that is going to be given acting for a period of 1 to 3 hours. So this is what I told you. Therapeutic classification of drug as per your KD Tripathi. So now, why you go for the sympathomimetics? Okay, I'll tell you. Sympathomimetics are going to help in various ways. So that is you're going to call it as a uses of sympathomimetics. So sympathomimetics can be used as a different drugs. First, so they are going to be used in the anaphylactic shock. They are going to be used in the cardiac arrest. They can be used in the controlling of hemorrhage. They can be used as a local anesthetic. They can be used in bronchial asthma, glaucoma. In the various conditions, we are using sympathomimetics. Is it clear? Okay. Now coming to the norepinephrine. Norepinephrine, they are going to be acting as agonists in alpha 1, alpha 2, beta 1, and relatively little in your beta 2. It is going to cause peripheral resistance and both diastolic and systolic blood pressure. Okay, now coming to directly acting sympathomimetics. I already wanted to tell you that in the drugs classify you can divide into directly acting, indirectly acting. Directly acting na direct adrenergic receptor la act panadhu. Indirectly acting by releasing noradrenaline from the nerve terminals. Mixed na both direct and indirect இருக்கும். Fourth one is catecholamine uptake reuptake inhibitors. So the catecholamine reuptake agudilla adha inhibit pannalam. So these are the 4 various ways how your adrenaline is going to act. Okay, so now coming to the phenylephrine. Phenylephrine is relatively pure alpha 1 agonist. In the point that you note pannu. It is a pure alpha 1 agonist. They are not catechol derivative. They are inactivated by COMT. Okay, so and longer duration of action than your catecholamine. So then the effective mydriatic and decongestants can raise your blood pressure. So your main value they can raise your blood pressure. That's phenylephrine oda vela. Next is going to be midodrine. Midodrine is a pro drug which is enzymatically hydrolyzed to desglymidodrine. So this is selective alpha-1 receptor agonist. This is selective alpha-1 receptor agonist. Alpha-1 receptor selective is மூணு drug. Phenylephrine, methoxamine, methylphenidate. Okay va? இவங்க மூணு பேர் தான் வந்து பாத்தீங்கன்னா alpha-1 ஸ்பெசிஃபிக்கா ஆக்ட் பண்ணும். Okay, next coming to the alpha-2 selective agonists. What are the alpha-2 selective agonists? So they are going to decrease your blood pressure in your central nervous system. They are going to directly act on the blood vessels and cause vasoconstriction. What are the example? Clonidine, methyl-dopa. What are the example? Clonidine, methyl-dopa. So இப்படியும் நான் வச்சுக்கிறது it's good தான். alpha-1 மட்டும் block பண்ணது என்னன்னு நம்ம பார்த்தோம், phenylephrine பார்த்தோம், then your midodrine. Okay, so then alpha-2 மட்டும் block பண்றது clonidine. So alpha-2 மட்டும் stimulate பண்றது clonidine and methyl-dopa. They are useful in the treatment of hypertension. So sedation is one of the important side effects. So then you are going to have a moxonidine, relminidine. This ரெண்டுமே alpha-2 agonist oda newer types. What are the things I told you now? One is moxonidine, other is relminidine. Okay va? So dexmetodrine அப்படிங்கிறது it's a sedation initially given to the intubated and mechanically ventilated patient in the ICU. Tizanidine is used as a central muscle relaxant. Okay va? So these are the different drugs that are available in your market. And then you are going to have very important xylometazoline and oxymetazoline. So these are the nasal decongestants which will be acting directly on your alpha agonist. So they will be promoting constriction of your nasal mucosa. Large doses of oxymetazoline will cause a hypotension, central clonidine like effect. Then you are going to have isoproterenol. So what is this? Isoproterenol. Isoproterenol அப்படிங்கிறது what it is, எந்த group கீழே வரும், or what is going to be the function of your isoproterenol? Someone? What is the action of isoproterenol? So they are going to be a positive chronotropic and inotropic action. They are going to have a positive chronotropic inotropic action. They are going to be a potent vasodilator. There will be increase in the cardiac output with a fall in the diastolic and mean arterial pressure and lesser decrease or a slight increase in your systolic pressure. So this is your oxymetazoline, this is your dexmedetomidine, and this is going to be your isuprel. Okay va? So now coming to the beta-1. So if alpha-1, alpha-2 rendu paathirukom. Can someone repeat what will be the alpha-1? Alpha-1 agonist is phenylephrine, midodrine. Alpha-2 la clonidine, methyl-dopa, moxonidine and relminidine, dexmetodrine and tizanidine. Okay va? So all nidines drug. So ellame ends as a NIDINE. All ends as NIDINE. Is it clear? Next one on the xylometazoline, oxymetazoline and isoproterenol. இவங்க மூணு பேருமே வந்து they are going to be an alpha receptor action. Okay va? But remember, isoproterenol will be having a potent beta receptor agonist and very small effect in your alpha. Next I am going to move towards the beta-1. So beta-1 selective agents is going to include dobutamine. Beta-1 selective agents அப்படின்னு பார்த்தீங்கன்னா it is going to be including dobutamine. So they are lesser effective in beta-2 receptor, increases your cardiac output with less reflex tachycardia. Dobutamine is a racemic mixture of a positive and negative isomer. Activation of alpha-1 receptor probably explains why peripheral resistance does not really significantly, because this is going to also activate alpha-1. So this is also going to activate alpha-1. Now coming to mixed acting sympathomimetics, ephedrine. Ephedrine is a non-catechol phenyl isopropyl. So they have a high bioavailability, long duration of action will be there. Significant fraction is excreted unchanged. Central nervous system is mild stimulant. Phenylpropylamine is a appetite suppressants. They are removed from the market because they are causing hemorrhagic stroke. That's why ephedrine is removed from the market. So this is your ephedrine and pseudoephedrine. Now indirectly acting sympathomimetics. Number one is going to be your amphetamine. Amphetamine is important chiefly because of its use and misuse as a central nervous system stimulant, because the usage of as a central nervous system stimulant. Okay, so that is why it is used. Amphetamine, this is a synthetic compound which is going to have a similar action like your ephedrine, but what happens is tachyphylaxis can occur on the repeated use. Your amphetamine produces most of its effect by indirectly acting by promoting the release of noradrenaline from the central noradrenergic nerve terminal. So what happens in your central nervous system? Remember, amphetamine patti neenga nariya padipenga when you go for a central nervous system. Inge namak enna important ah thevana, idu vandu blood brain barrier cross panni pogum. Since it is going to cross your blood brain barrier, they are going to cause increase in the mental activity, physical activity, alertness. Mental activity, physical activity, alertness. Okay, so இது எல்லாமே வந்து it is going to us. Okay, and it also increases the initiative and self-confidence. It is going to postpone your fatigue, sleep, and it is going to improve the physical performance temporarily, as you can see in the any athletes amphetamine use பண்ணுவாங்க. But what happens long term la amphetamine are going to cause addiction. That is why we are not using. Next, coming to the respiration, amphetamine is going to stimulate your respiratory center and it is going to suppress your appetite. But what will be the adverse effect of usage of amphetamine? They are going to cause restlessness, they are going to cause tremors, they are going to cause insomnia, they are going to cause palpitation. Okay, so higher dose of amphetamine usage will be crossing headache, nausea, vomiting, abdominal cramps. So எங்கெல்லாம் நம்ம amphetamine use பண்ணுவோம்? Amphetamine we usually use in the attention deficit hyperactivity disorder, ADHD, or narcolepsy. So narcolepsy we will be going for the amphetamine, especially methylphenidate or modafinil. Then obesity, epilepsy we will be giving. Clear? So this is methylphenidate. It is effective in some children with attention deficit hyperactivity disorder. Modafinil is a psychostimulant. Both norepinephrine and dopamine transporter, they are going to cause wakefulness in narcolepsy. Tyramine அப்படிங்கிறது they are going to parenterally administered indirect sympathomimetic action, which is going to cause release of the stored catecholamine. So this is going to cause release of the stored catecholamine. What is this drug called as? Tyramine. What is this drug called as? Tyramine. Is it clear? Okay. Now remember, so tyramine is going to be causing metabolized by MAO. Patient taking MAO inhibitor must be careful to avoid tyramine containing food. So then comes a catecholamine reuptake inhibitor. What are the catecholamine reuptake inhibitor? Atomoxetin. Atomoxetin is a selective inhibitor of your norepinephrine reuptake transporter. So they have little CVS effect. So they are frequently causes orthostatic tachycardia. They are also used in attention deficit disorder. Then you are going to have duloxetine. So duloxetine is used as an antidepressant with a balanced serotonin and norepinephrine reuptake inhibitory effect. Now coming to the therapeutic usage of a sympathomimetic drug. Number one is anaphylaxis. Always remember, adrenaline is a drug of choice. 0.3 to 0.5 ml, 1:1000 solution. It promptly reverses your hypotension, laryngeal edema, and bronchospasm, and they are going to be a life-saving in your anaphylactic shock. Adrenaline is a life-saving in your angioneurotic edema. இது ரெண்டுத்திலுமே anaphylactic shock, angioneurotic edema ரெண்டுத்திலுமே adrenaline is going to be a life-saving drug. Clear? So IM route is preferred as absorption by SC route is not reliable in the shock. Then you're going to have a cardiac arrest. So sudden cardiac arrest. Okay, cardiac arrest we will be using. Why? When there is a sudden cardiac arrest due to some drowning, due to electrocution, okay, you will be going for a CPR. While giving a CPR, intravenous or intracardiac administration of 1 mg. Okay, 1 mg, if you are going to inject, it will be ensuring that the heart is going to return back to its normal inotropic effect, inotropic state. Then controlling your hemorrhage, very important part. So adrenaline is used as a 1:10,000 or 1:20,000. Okay, concentration as a topical hemostatic to control the bleeding. So இத நான் எங்க பார்க்கலாம்னா நீங்க யூசுவலா casualty just if you go if there is any bleeding case ஒரு ரொம்ப bleed ஆகுதுன்னா அந்த இடத்துல adrenaline வச்சு they will be giving a local application. Okay, then coming to local anesthetic. When you are going to inject local anesthetic along with adrenaline, they are going to produce vasoconstriction and they are going to reduce the rate of absorption of LA. By this, it is going to prolong the action and reduces the systemic toxicity of a anesthetic agent, that is local anesthetics. Then you have the pulmonary application. What is the pulmonary application? So through the subcutaneous or inhalation, adrenaline produces a bronchodilation. So that is one thing. And next is in the ophthalmic application, that is your glaucoma. Ophthalmic application enga neenga use பண்ணுவீங்க in a glaucoma. So what happens in the glaucoma? Remember, so adrenaline is going to decrease your intraocular pressure. Adrenaline is going to decrease your intraocular pressure. Adrenaline decreases your intraocular pressure. And what happens is, so it can be used in glaucoma. But what is going to be the disadvantage? Always remember the disadvantage is one thing, it is poorly absorbed. It is poorly absorbed. Second thing, it is a short acting. It is a short acting drug. So that is the reason it is not used in the ophthalmic application. Okay, already central nervous system application சொல்லியாச்சு, genitourinary system application சொல்லியாச்சு. Okay, so now you know dopamine, dobutamine, அப்புறம் வந்து you also know about the non-catecholamines like ephedrine. You know the okay, ephedrine இருக்குல்ல, right? I'll just go back and talk about this ephedrine again. So you talked about this one drug called as ephedrine, isn't it? Even now ephedrine is used. Why ephedrine is used? In bronchial asthma, ephedrine is useful, but it is not preferred. Nasal decongestions. Anga pseudoephedrine abdin or drug varudhu. So this is your pseudoephedrine. What is the pseudoephedrine? Pseudoephedrine is an isomer of ephedrine and it is going to be used orally for nasal decongestions. It is going to cause vasoconstriction. Engala vasoconstriction pannu skin mucous membrane, but its effect on the CNS and heart is going to be milder. Adinada ephedrine compare pandrappa nor a pseudoephedrine is used in the market. Okay, then midriasis you use hypotension, narcolepsy and Stokes-Adams syndrome. Angala nama use pandrom. Now you know the you also know about the amphetamine, isn't it? Then vasopressors. Ipa now coming back to the that therapeutic usage. So இப்போ வந்து நீங்க அந்த உங்களோட கேடி ட்ரிபாத்தில இருக்கக்கூடிய அந்த கிளாசிஃபிகேஷன்ல ஃபர்ஸ்ட் என்ன எடுக்கிறீங்க? பிரஷர் ஏஜென்ட். வாட் ஆர் த பிரஷர் ஏஜென்ட்? அகைன் ஐ ரிப்பீட், நார்அட்ரினலின், எஃபெட்ரின், டோபமைன், ஃபெனிலெஃப்ரின், மித்தாக்சமைன், மெஃபிட்டரமின். ஸோ இதெல்லாம் தான் வந்து பார்த்தீங்கன்னா வாசோப்ரெசர். ஸோ இவங்க எல்லாருமே they are called as vasopressor. ஓகேவா? ஸோ then comes the nasal decongestions. So what are the nasal decongestions you are going to use? So you are going to use two things, oxymetazoline, xylometazoline. They are going to be acting orally. Oxymetazoline, xylometazoline. Again phenylephrine, pressure agent la பாத்தீங்கல்ல, அது again இங்கேயும் வரும். Nafazolin, அதுவும் இங்க வரும். ஓகேவா? pseudoephedrine, நம்ம ephedrine யூஸ் பண்றது இல்ல, அதுக்கு பதிலா what we are going to use? pseudoephedrine. So இப்ப nasal decongestions கீழ நீங்க என்னெல்லாம் நான் வச்சுக்க போறீங்க? xylometazoline, okay, oxymetazoline, nafazoline, phenylephrine, pseudoephedrine. இந்த அஞ்சை தான் you are going to remember. இப்ப ரெண்டு குரூப் ஆஃப் கிளாசிஃபிகேஷன் நல்லா தரோவா தெரியுமா? நெக்ஸ்ட் ஒன் மூணாவது என்னது? ஓகேவா? சோ இதுல இதோட அட்வர்ஸ் எஃபெக்ட் என்ன? when you are going to use a nasal decongestants for a prolonged period of time, they are going to cause one important thing, rebound congestion. So what is a rebound congestion? So when you are going to stop the usage of the drug, what happens is there might be again congestion that is going to be occurring. So that is called as rebound congestion, and there will be atrophy of your basal mucosa due to the intense vasoconstriction. Clear? It is used in rhinitis, it is used in blocked eustachian tube also. Similarly, okay, what will be happening in acute hypotension? When there is a severe hemorrhage, when there is a decreased blood volume, when there is a cardiac arrhythmia, neurological disease, antihypertensive drugs எடுத்துக்கிறது, அங்கெல்லாம் வந்து பாத்தீங்கன்னா acute hypotension இருக்கும். அங்கெல்லாம் if you are going to give norepinephrine, phenylephrine, methoxamine. They are going to cause alpha agonist. Alpha is going to be causing vasoconstriction. They are going to cause vasoconstriction, and this leads to increase in the blood pressure. It is going to cause increase in the blood pressure, and it is going to solve your acute hypotension. And similarly, shock, same thing, same mechanism. Isotretinoin and epinephrine have been used in the temporary emergency management of your complete heart block and your cardiac arrest. Dobutamine injection is a pharmacological cardiac stress test. Epinephrine is usually applied topically in the nasal packs and gingival. So epinephrine 1:2 lakhs is going to be used. Bronchial asthma, beta 2 selective drugs. So what is beta 2 selective drugs? That's next in our paper. So that is called as your bronchodilators. So if bronchodilator beta 2 தான் bronchial smooth muscles specifically beta 2 target பண்ணோம்னா, okay, it is going to give an increased action. That is called as selective beta 2 agonist. What are the selective beta 2 agonists you're going to have? So selective beta 2 agonist is salbutamol, terbutaline. Though we have isoprenaline, so giving a salbutamol, terbutaline, so it is going to be a selective beta 2 agonist. Okay, so they are going to be used in the bronchial asthma. And bronchial asthma mattum use பண்றோமா அப்படினு கேட்டிங்கனா, no, you are also using it in the uterine relaxants. அதனால தான் salbutamol, terbutaline, even under the classification of uterine relaxants, they will be giving. But apart from it, they are given two more in the uterine relaxant. என்னென்ன? Ritodrin, isoxsuprine. What is ritodrin and isoxsuprine? Isoxsuprine is a selective beta stimulant used in the uterine relaxants. In case of a premature labor, in case of a threatened abortion, in case of a dysmenorrhea. So what are the other bronchodilators? You have salmeterol, formoterol, bambuterol. These are next advanced versions. Okay, so இதெல்லாம் நம்ம பார்த்துட்டோம். Next one, what is the other thing next you are going to see? Beta 3 agonist. What is this beta 3 agonist? Beta 3ங்கிறது overactive bladders இருக்குல்ல, overactive bladders. அங்க you will be using. What is the drug? Mirabegron. So இது நீங்க common when you go for a urology posting, you will be having this drug called as Mirage. What is this Mirage drug? It is nothing but Mirabegron. What is this Mirabegron? They are the selective beta 3 agonists used to treat the overactive bladder. Okay, since beta 3 agonists also promote lipolysis, they also have a role in obesity. They are also going to have a role in obesity. Another thing I want to tell is anorectic agents. What is this anorectic agents? You are going to have anorectic agents like your amphetamine. So amphetamine suppresses your appetite. So it is anorectic agent or anorexia. Other drugs are fenfluramine, dexfenfluramine, mazidol, phenylpropanolamine, and fenmetrazine. இதுல ஏதாவது ஒரு drugs நீங்க now வச்சுக்கணும். So some drugs you remember out of the anorectics. Okay, some drugs you remember from the anorectics. So till now is it clear? So இப்ப இதுல pressure agent பார்த்துட்டோம், bronchodilators, CNS-ல amphetamine, dexamphetamine, methamphetamine, methylphenidate. Uterine relaxants, you're going to have salbutamol, terbutaline, and you're going to have ritodrin, isoxsuprine. Anorectics, you're going to have amphetamine, fenfluramine, dexfenfluramine, sibutramine. Then you're going to have nasal decongestants, oxymetazoline, xylometazoline, nafazoline, phenylephrine, pseudoephedrine. Cardiac stimulant, you're going to have adrenaline, isoprenaline, and dobutamine. Bronchodilator, again, you're going to have isoprenaline, salbutamol, terbutaline, salmeterol, formoterol. Pressure agent, you're going to have noradrenaline, ephedrine, dopamine, phenylephrine, methoxamine, and mefthiramine. Okay, so I think you all remember this. And what we are going to see is phenylpropylamine. அப்படின்னு ஒரு drug நம்ம பார்த்தோம் நடுவுல. But இப்ப அது banned. Why? Because of the risk of stroke. Catecholamine reuptake inhibitor. What is the catecholamine reuptake inhibitor? Several drugs are going to inhibit the uptake of noradrenaline and dopamine by inhibiting your amine transports. Okay, that is atomoxetine, riboxetine. இவங்க ரெண்டு பேருமே selectively they are going to inhibit norepinephrine uptake transporter. Therefore, they are potentiate noradrenergic transmission. So noradrenaline reuptake inhibitors like your duloxetine are also used in the depression. So இது எல்லாமே தான் உங்களுக்கு adrenaline, noradrenaline. I think I have covered all the adrenergic and noradrenergic group of drugs. Till now, if there is any doubt, you just let me know in chat box. I'll give you 1 minute. So quickly go through in your mind whatever thought now. If you want, we can go for the next topic. That is going to be adrenergic blockers. If not, we will continue tomorrow based on your opinion in the chat box. Now, I request you to just put down in the chat box so that we can decide and proceed accordingly. Good. I think you all understood whatever thought till now. So we will continue the adrenergic blockers tomorrow itself. Most probably around tomorrow 7 o'clock. If you are all free, we will continue at 7 p.m. Okay. Thank you so much. Let's go to just revise quickly. Once the session ends, just switch off the video. Then you revise yourself whatever thought. Because unga book வந்து எப்படி கொடுத்திருக்குன்னா, remember your book is going to give you based on the actions. What I taught you is based on the receptors. Why I taught you based on the receptors is when it is going to be asked in the exam. Example, amphetamine அப்படின்னு நம்ம கொடுத்தாங்கன்னா, what people know is it is a CNS stimulant. But what people doesn't know is what is the action, what is the receptor where it acts. Now I think you know what is the receptor where your amphetamine acts, because amphetamine is going to now act in, anyone? Just mention this in your chat box so that we can conclude. Amphetamine is going to be acting in the which receptor? They are indirect acting sympathomimetics. How they act? It is going to it is not going to be increasing. It is not going to be acting on alpha or beta. Rather than it is going to indirectly promote the release of noradrenaline from your central noradrenergic nerve terminals. Thus will be increasing the dopamine release. That will be increasing your noradrenaline release. This is how your amphetamine works. But CNS stimulant and mattum namakku therinjuna no use. It is an indirect sympathomimetics. அதுதான் நமக்கு தெரியணும். Similarly, your phenylephrine is a alpha 1 specific. All your salbutamol, terbutaline is a beta 1 specific. So your isoprenaline, dobutamine is beta 1 specific. So your oxymetazoline, xylometazoline are alpha 1 specific. So I will send this PDF in the group also. So you just read that based on the agents that are going to act on which receptor. That will only help you to crack your exam well, to understand and replicate in your exam well. Thank you so much. Let's see tomorrow.